Good afternoon, everyone. In the next 20 minutes, I will take you through the existing body of literature on the role of definitive therapy in oligometastatic breast cancer. Before I begin, I would like to emphasize that I don't intend to show you a presentation full of Kaplan Meier curve. In fact, there are less than four in this presentation. I will try to present the review of literature as objectively as possible rather than only presenting the results of studies because my purpose today is to orient your thoughts in a manner which accentuates your understanding and hopefully benefits your patients. Very briefly, I will go through the theories and rationale behind the treatment of oligometastasis, followed by the approach for de novo and metacronus metastatic breast cancer. We will be reviewing the literature with an emphasis on pooling data to gain insight into this challenging and interesting situation. We will also briefly touch upon induced oligometastasis and oligoprogressive state before concluding with some key messages. So, deviating from the concept of dichotomous status, Hellman and Wasselbaum introduced the concept of an intermediary, less aggressive stage, namely oligometastasis. There was some evidence that these patients do distinctly well when treated with aggressive approach with a caveat of Will Rogers phenomena because of increase in imaging sensitivity in the recent years. Also, defining limit and when to say polymetastatic disease is still an ongoing process. And the concept, as described in Norton-Simon hypothesis, is the development of kinetic resistance in patients with small volume residual disease post-systemic treatment. So introducing local ablative therapy at this time can pull back tumors into a zone where systemic treatment is more effective. And this can be done at multiple time points with an intent to increase overall survival. Further, to add on to this, with the advent of immunotherapy, there is a phenomena of immune enhancement and abscopal effects. This term abscopal effects we have been listening for now last so many years. And lastly, but not the least, there are still some patients who do exceptionally well. Let's call it the act of God hypothesis. So over the next few slides, let's go through the de novo oligometastasis literature. And so let's see how real world patients from multi-institutional cancer registries have done when treated with evolving standard of care systemic treatments over the last 4 or 5 decades. And there is no doubt that we have seen consistent improvement in median overall survival from 20 months to 36 months over the last 40 years. Let's remember this, and we will be using this figure as our reference while understanding the management of oligometastatic disease. While not strictly a part of the topic assigned to me, I have always been curious as to why these four phase 3 trials, which were studying the impact of loco-regional therapy in the setting of metastatic CA breast, failed to move the needle. Let's leave aside the fact that individual trials had different designs and imbalances. The most important factor which I noted when I read these trials was the proportion of patients with oligometastasis. They were ranging between, in almost all the trials, between 25 to 30%. So plotting the results of these trials on the real world chemotherapy data I showed previously, the results are on both sides of expected median survival for the time period in which these trials were performed. Green bars are control arms, red bars are trial arms, and the width of the bar represents the study time period. There is another recent trial which had about 20% of patients with oligometastasis from breast primary, the Saber Comet trial by David Palmer, and its results for both trial and control arms fit perfectly into the curve of expected median survival. Why this is important to emphasize is because if you can imagine that you have a patient with oligometastatic breast cancer in your clinic tomorrow, and assuming if all these trials were actively recruiting patients, could your patients be randomized into the arms of these 5 trials, like a mega trial, one mega trial? I sincerely think yes. And if so, then the transitivity assumption is satisfied And this is the key concept of a network meta-analysis, where direct and indirect comparisons can be evaluated objectively. So let me give you a quick example where we have a direct comparison of a height between a tower A versus B and a tower B versus C. But what we don't know is the comparison of A with C. The simplest way is to travel to Paris and New York to perform a direct comparison between A and C, but this is not prudent as it involves finances and travel during an ongoing pandemic. And the same is true in oncology, where we can't design a trial for each and every intervention because of so many logistic reasons. But we can estimate the relative difference by using a network meta-analysis. It is a powerful tool to compare multiple interventions for the same condition, assuming the transitivity assumption is satisfied, as we can intuitively figure out that the building C might be taller than building A. So with that background, let's come back to the topic at hand, role of locoregional treatment in metastatic breast cancer. So we did this analysis as a part of an ongoing project, and I'm happy to share some preliminary results and insights with you today. There were 1,069 patients in the network, and we performed a specialized meta-analytic technique known as Bayesian network meta-analysis for 3-year risk of death, in which our prior knowledge about a certain situation influences the result of our analysis. So if you are interested, we can discuss its nuances at the end of my talk. So we ran a fixed and a random model on all patients and found that patients receiving local treatment to oligometastatic site were doing marginally better compared to all other arms. Not the least surprising considering that we included patients from Saber Comet trial, but upon removing the trials which did not report treatment outcomes of oligometastatic patients, the ABCSG and ECOG trial, results strongly favor the combination of surgery with local therapy to oligometastatic sites, even though the treatment offered to oligometastatic patients in the TMH arm was unknown. While the results were not significant in the random effect model, that's likely due to a small number of patients left after excluding 2 large trials, and before dismissing these results as a statistical fluke or the undue influence of Saber Comet on the analysis, let's look at the performance metric of the two analyses by plotting leverage versus residual deviance to identify the presence of any outlier and to see how closely these included trials fits. Closer the better. Remarkably, the Saber Comet trial is not exerting an undue influence and the trials are closely bunched together. In fact, the individual trials which remained after excluding 2 trials came even closer. Perhaps the result of phase 3 trial from Japan, JCOG 1017, with similar design as E2 108 trial, which was included in this analysis, will further increase our confidence. But it must be said that the observations from our analysis are not without a precedent. Please have a look at this large registry analysis from Netherlands. The authors analyzed and balanced patients surviving more than 10 years with those surviving for a shorter duration. And the survival curves show a clear separation between those patients with the 3 or fewer metastases versus more. Even more interesting is that in patients who had 3 or fewer metastases, they found a remarkably better survival, which was 42% survival advantage with the administration of locoregional treatment. So my guess will be that if locoregional therapy has to remain relevant in the years ahead, we will need to stratify patients in clinical trials by the number of metastases or conduct a trial in patients with 3 or fewer metastases. Probably this may actually give us results which may change how we deal with these metastatic CA breast cancer patients. So shifting our attention to Metacronus oligometastasis now, I again present the real world results with systemic therapy in Metacronus metastatic setting. And if we superimpose the curve from the de novo metastatic setting, it is clear that these patients experience a slightly longer median survival, and in more recent decades, the curves are separating even further, implying a longer recurrence-free interval with improved adjuvant therapies. So where do we stand when it comes to the literature on local therapies in the Metacronus oligometastatic setting? We performed a systematic search of the literature on only breast cancer, and it can be broadly divided into those with an intracranial and extracranial metastasis. We found 7 series with intracranial disease outcomes and 12 studies describing extracranial disease only, which was further divided by site specific studies. And these were then classified by the predominant type of intervention which was delivered. So, using the reference of systemic therapy, SBRT for medically inoperable patients with lung metastasis is established as the standard of care. However, unarguably, the standard of care for all other patients is a surgical resection, and the literature is vast and varied. We found a meta-analysis which included more than 1200 patients and 16 studies over 3 decades, and the reported median overall survival is indeed impressive and ranges from 31 to 96 months. It also needs to be mentioned that while surgically fit patients tend to do better, all things considered, if SBRT can match outcomes in medically inoperable, poor performance status patients, perhaps SBRT could be a future option in medically operable patients as well. Inspired by the success of lung metastasis, surgical metastectomy has also been reported in liver oligometastasis with mixed result, likely due to older series with undiagnosed polymetastasis due to reduced sensitivity of imaging techniques at that particular time period. And here median overall survival ranges from 12 to 58 months. SBRT is suitable for most lesions up to 5 to 6 centimeter in size located centrally, while series on thermal ablation have demonstrated comparable efficacy to surgery, and both modalities demonstrate impressive results. Bone metastases are unarguably the forte of SBRT with results far and above surgical resections. However, in defense of surgery, I must say that the role of surgery is hampered by its use as an emergency procedure, impending malignant spinal cord compression or quality of life altering fractures procedures where margin considerations are secondary, thereby explaining the poor results. Therefore, the median survival comparisons are not valid actually. The journey from whole brain radiotherapy to SRS is a lecture on its own, but I will stick to the key highlight. While it's currently fashionable to criticize whole brain RT for its shortcomings, it has served us well in past. Before the turn of the millennium, whole brain RT was all we had, and it offered something to the patients and their families. With the development of SRS, early results suggested that it had an incredible local control rate with several advantages over whole brain radiotherapy, but had a higher intracranial failure rate, which is why investigators focused on adding whole brain RT to SRS. But a meta-analysis by Dr. Arjun Sehgal cemented the place of SRS in the management of 1 to 3 brain metastases. And while SRS was making great strides, the Quartz trial suggested a diminished role of whole brain RT, though this trial had its own flaws. So an alternative whole brain RT technique was developed which preserved neurocognition by sparing the hippocampus while simultaneously delivering a higher dose to macroscopic lesions. It is not implausible to assume that our current preference of radiotherapy technique based on numbers alone will evolve from hippocampal avoidance whole brain RT to more than 4 metastases to more than 10 metastases. And there is emerging endorsement for this approach from American Radium Society, and hopefully ongoing head-to-head trials comparing SRS with whole brain radiotherapy will answer this question in near future. So since I promised I won't be showing Kaplan-Meier curves, we wanted to demonstrate the result of all these studies using a meta-analytic technique. While most meta-analysis deal with synthesizing evidence on treatment effects through the difference between outcomes of different arms, it may be of interest to obtain a valid summary estimate of the incidence of events over different single-arm studies. So the pooled estimate of single-arm studies is shown in next few slides, and the outcome is the 2-year mortality rate. So if we are near 1, then that trial is doing worse. If we are near 0, then that trial is doing best. So upon pooling results stratified by site, it becomes immediately apparent that patients with intracranial oligometastasis disease have the worst 2-year mortality, while oligometastatic bone disease fares best. And if we add the pooled results of 3-year mortality from surgical series, it fares slightly worse than other local modalities. It is also fair to say that this is not a strictly statistically valid comparison as the time points are different. We are currently working on this, but the true estimate value would lie somewhere at this particular place. Similarly, for lung metastasis, results were available for 5-year mortality, and we expect the true pooled results to lie somewhat here. So, pooling the results of Metacronus oligometastasis by technique, they appear comparable with the risk of 2-year mortality less than 20%. Similarly, for bone metastasis, risk of 2-year mortality is less than 20%, while thermal ablation has the lowest risk of 2-year mortality, which is less than 10% for liver lesions in the included series. My take on these results is that we have to rise above the trials, comparing modalities, and utilize the multidisciplinary tumor board to decide between modalities at our institution. Every case in which local therapy is being contemplated, the management has to be decided in the tumor board. Though it is difficult to convince surgeons, and they usually, but not always, win the discussion, but then the patient ultimately wins, and that is the ultimate goal. Moving our attention to induced oligometastasis, a category of patients who have been successfully downstaged from polymetastasis, there is some apprehension in the medical oncology community towards local treatment owing to the fact that it's their effort which successfully downstaged the patient. But as this single-arm phase 2 trial shows, the survival of patients with induced oligometastasis is no different from those with de novo oligometastasis. Granted that the number of patients with induced oligometastasis was only 25%, and most patients had bone lesions, with majority being hormone receptor positive. So overall, they were good prognostic group of patients. It must also be pinpointed out that the apprehensions of the medical oncology community are unfounded, as 65% of patients received concurrent chemotherapy with SBRT. What about other categories of oligometastasis as described in ESTRO URTC consensus statement on the classification of oligometastasis? At first, I was concerned that I didn't find much literature on these newly defined categories of oligometastasis. Two abstracts presented at ESTRO last month highlight the dearth of literature. So Guckenberg et al. Presented the results of a systematic research search in which most newly defined categories of oligometastasis actually don't have any literature. And he also presented the number of patients in the OligoCare project with these newly defined categories. And again, we can see if we specifically look at breast, the dark blue color, there's very small number of patients in these newly defined categories. We need to combine our data set to create a similar repository of patients, probably to gain more insight and to do justice to our patients. So before moving on to future concept, here are my conclusions on the question posted to me: where are we? We need to stratify patients with oligometastasis in future trials investigating loco-regional therapy, and we urgently need an individual patient data meta-analysis on the existing trial. Probably if everybody can contribute to it, then probably we can definitely gain some better insight into this particular problem. My conclusion on local therapy for sites are in line with most consensus guidelines: surgery for lung, SBRT for bone and brain metastasis. Management is currently in evolution phase. At our institutions, we have treated up to 16 brain metastases with definitely with low combined volume of lesions. And finally, we need to pool our resources to better understand the diversity of these oligometastatic patients. Several interesting trials which are ongoing will further enhance our understanding in the coming years. As a quick snapshot, I'm particularly interested in the Oligma trial, as it is testing SBRT to the primary site as well somewhat similar to the trials of loco-regional therapy. From a technical perspective, I am anticipating the results of Saber Comet 10. Treating 10 metastases will be demanding, but I believe our radiation oncology community will rise to the challenge. A new frontier of neoadjuvant SBRT may open up based on the Boston 2 trial, which is testing immune activation with SBRT followed by PD-1 inhibitors. Last but not the least, I am looking forward to the arrest trial. If treating 10 lesions will be challenge, imagine treating all metastatic lesions in a patient. Look at the dose distributions in these dosimetric study. Looks a lot like a total body irradiation with hotspots. Very interesting and very challenging indeed. We still have a lot to learn and lot to discover. Thanks for your kind attention.